Good morning and welcome everybody to our webinar entitled To Vaccinate or Not, where we will be demystifying the vaccine, COVID-19 vaccine, by connecting you to one of South Africa's leading medical experts. My name is Zanele Jafta and I will be your host today. COVID-19 has been very topical in the past few months, and there has been competing narratives about the vaccines. This has resulted in many eligible segments of our society being hesitant in being vaccinated. This webinar will provide you with the medical facts about the vaccines. While we are connecting with you online in this way, and it is important to reflect on your own connections and your own connectivity, especially when it comes to your health and financial matters. At Nedbank Private Wealth and Nedbank Financial Planning, we use our globally integrated and advice-led approach to connect your financial decisions to your goals and aspirations. The reality is that every single financial decision we make affects our ability to protect what is important to us and to achieve our goals and objectives. Your money decisions connect your goals, your needs, your dreams, and fears and attitudes, and the role that you play in your community on how you earn, spend, and save your money. We connect you to our technical expertise, a global perspective, appropriate opportunities, and access to solutions and services from across Nedbank and our financial partners. But most importantly, we connect you to the personal and objective advice you need to make your money decision count. And that is what we call connected wealth. Before we get to our topic for today, I'd like to go through some housekeeping with you. On your left-hand side, you will find a Q&A chat box. Please use that to submit your questions, and I'm sure our guests will be more than happy to answer those questions. And if it happens that your screen freezes during the webinar, please press the refresh button and it will take you back to where you stopped last in the webinar. You will also receive an email in the next few days with a link to a recording of the webinar, in case you would like to share this or watch it again. We're very privileged to have Derek Watts and Professor Glenda Gray as our guests today. Derek is a well-known award-winning journalist and a television presenter with 40 years broadcasting experience. Derek will be hosting our conversation today with Professor Glenda Gray. Professor Glenda Gray is the first female president and CEO of South African Medical Research Council. She was the chair of the Research Committee on COVID-19, bringing together scientific evidence and experience to the Minister of Health and the National Coronavirus Command Council. Professor Gray spearheads the South African Medical Research Council funding broadly and for COVID-19 as well. And without wasting any more time, I'm going to hand over to Derek Watts. Derek, over to you.
Zanele, thank you very much, and greetings to our participants, and a very good morning to Professor Gray. How are you this morning?
I'm good.
Busy as always, I'm sure, and the week started on a busy note with your virtual meeting with your counterparts in the UK regarding the red list, and maybe some impressions they had of the beta variant that you updated them on. Just tell us briefly how that went.
I think it was very important to meet with them because it's quite clear that they were behind on their knowledge of South Africa. We have a very sophisticated testing strategy as well as a good strategy to watch the evolution of the virus in South Africa. And I think they were unaware of the depth and the sophistication of our program. And so we had to explain that Delta has replaced Beta in South Africa. And they were concerned about certain parts of the country. And we explained our methodology where we do the random evaluations of breakthrough infections to make sure we can see what's happening with virus, with the viral evolution. So we spoke about that. We spoke about the epidemiology of COVID and our testing rates, as well as vaccine passports and issues around how one gets, how one establishes the risk, the robot system, and how often you review it. And also we stress the importance of better communication between the two countries, so that this kind of thing doesn't happen. So we are hopeful that we'll be taken off the red list, and that we can work with them more closely and share our data more easily to improve the assessments that people make of countries. And so I think that was very useful to have that conversation with them.
And this morning's news is the president's getting involved. So we are hopeful, I guess, of that review, which should be in the next couple of weeks. Professor, my wife tells me it's not all about me, but I thought I'd be honest about my approach to the pandemic. I worked on the stories on the AstraZeneca trials, which didn't work out so well. There was the J&J shipment, which was condemned by the FDA. I did many interviews with leading scientists, and they didn't all agree. The stories abounded on the rumor mill, heart surgeons that wouldn't have the vaccine. I mean, we were totally overloaded with information and misinformation, and social media and TV. Even Dr. Fauci seemed to change his tune at times. The ivermectin debate raged, and the rollout eventually started. It was a confusing time, I think, for most of us. And to be honest, I was vaccine hesitant for a few months. But some aspects became fairly obvious. I mean, sadly, friends were dying, and not because of the jab. And I think we've all had that experience. I think hospitals here and in many places overseas were filled, wards were filled, mainly with unvaccinated patients. And on a selfish level, I knew that if I wanted to travel, I would have to eventually get a vaccination passport. Professor, now I know it riles you that there are people who are hesitant, but do you understand that there is certain confusion out there?
Yes, I think I understand. I think there's confusion because people don't think COVID-19 is a serious infection or a serious disease. And I think it's important to note that we are predicting that COVID will outstrip HIV as the biggest killer of South Africans this year. Already 150,000 people, if we look at our excess deaths, have died during our pandemic this year. And so it's very sad in our country. We have a devastating pandemic. We have high fertility rates, and people have died during the pandemic, and it's a very serious condition. You've had friends, I've had colleagues, I've had people who are anti-vaxxers who've died because of COVID, and that's incredibly sad. And so I think the first thing we have to acknowledge is that this is not a namby-pamby virus, and not all of us who get natural infection will survive it.
Professor, let's start with a basic question. Which South Africans over the age of 18 should not be vaccinated?
So I think it's a very important thing to try and understand the risks and benefits of vaccination, and to look at your risk-benefit profile, and talk to your doctor if you decide not to be vaccinated. There are rare side effects of vaccination. One of them obviously is anaphylaxis, and that occurs between 2 and 4 people per million vaccinations. And so if you have a history of allergy, it's important to speak to your doctor and alert the vaccination site about your allergies. And if well managed, you won't have any untoward events. So the vaccination sites are well trained for anaphylaxis, and that's important. The other rare side effects that one might have, and we saw that in the US and in South Africa, was with the J&J jab, which was the thrombosis with thrombocytopenia syndrome, or vaccine-induced thrombotic thrombocytopenia. And if well managed, again, is not fatal. We've had in the Sisonke study, we had we had three cases, and they were well managed and were not fatal. That's important. We've had also, I saw in the media and in South Africa and reports abroad of a Guillain-Barré syndrome. Again, if people have early, if it's detected early and well managed, these things are also not fatal. We've also heard of reports of, particularly in younger people and men with the Pfizer, the myocarditis and pericarditis, but these are all rare. So a lot of these events these rare events that I'm talking about occur between 4 and 8 per million vaccinations. And so if you're concerned about that you have a predisposition to thrombosis, or you've had a DVT or pulmonary embolus before, you can work with the hematologists who will guide you through your vaccination schedule. You also have to remember, if you've had a DVT or thrombosis or pulmonary embolus before, and you get COVID, you're at incredible risk of having really adverse events following your COVID infection. And so people with clotting predispositions need to work with their doctors and the vaccination center to make sure that they feel confident about being vaccinated. We have a hematologist on our program that we work with, and if there's any concern, we discuss things like anti-clotting agents 3 days before vaccination. But we don't suggest you do this by yourself, but that you work with teams and hematologists if you're worried about any side effects. So if you are worried about a side effect, or you have an existing ailment or disorder that you think is going to interfere with the vaccination, it's important to speak to experts and let them guide you through it, and not you make your decision by yourself.
Professor, is there a red flag for those who are HIV positive, especially if they're not on antiretrovirals?
So we are concerned about effectiveness of vaccines in immunocompromised people. So we do know that people who have had organ transplants or are immunocompromised or HIV infected may need additional boosting or may need additional doses. So the vaccine effectiveness may be lower if you're immunocompromised, and maybe lower if you're HIV infected, particularly if you're not your CD4 count or viral load. If your CD4 count is low and your viral load is high, and you're not taking your medication. So we do want people who are immunocompromised to be vaccinated, because they're even more at risk of dying from COVID disease, and so they're critical to be identified and be vaccinated. We in Sisonke, we had HIV infected healthcare workers who were enrolled, and we found that the vaccine was effective in that group, albeit slightly lower than a young non-immunocompromised person.
There was concern that some people who are HIV positive could harbor the virus for an extended period and be spreaders in that right. Any truth to that?
So any immunocompromised person, if they're HIV infected or if they've got cancer, we've seen this in the UK, people with cancer, maybe chronic spread, they maybe have chronic infection and may have chronic shedding, what we call chronic shedding. So you still have the virus in your nose and you shed it. And in immunocompromised individuals, you may find that viral evolution may occur, particularly with chronic shedders. And so we are concerned about people who are immunocompromised, because they may lead to viral evolution, because their immune system is interacting with the virus and it's not able to manage it and clear the infection. And so therefore we're at risk of viral evolution in those people.
So it's something that is being watched and researched. Professor, some questions from our Nedbank audience and others. Quick Q&As. Are all vaccines safe for pregnant women and breastfeeding mothers?
So if you look at the WHO recommendations and the associations for obstetrics and gynecologists, they will recommend vaccination of pregnant women and lactating women. And in South Africa, we also recommend it. Pfizer has been well researched in pregnancy and breastfeeding, and is used at a global level. We have also been evaluating the adeno 26 or the J&J jab in pregnant women, in pregnant healthcare workers, and are following them up. And so we do recommend that vaccines are critical for pregnant and breastfeeding women, because women who are pregnant have adverse outcomes if they get COVID. And we have seen that at a global level. Women who are pregnant are at risk of adverse outcomes for COVID. And so therefore, it's important for them to be protected. We recommend normally vaccinating after the first trimester and before 36 weeks of pregnancy. But we do see it at a global level that a lot of women are being vaccinated, and it's recommended given the risk-benefit ratio of having COVID when you're pregnant versus being vaccinated.
Professor, another question from a viewer. Is it true that we will only know after 2 years of being vaccinated if the vaccine has a negative effect on your body or not? Interesting.
Yeah, I think it's important to understand how vaccines work. So when you have a vaccine, it goes into your arm, your immune system develops an immune response to it, and the vaccine itself degrades. And usually we don't see any side effects after 28 days. Okay. But we continue to observe, particularly in the Sasonki, we follow up participants for 2 years to try and evaluate if there would be any side effects. But if we compare this vaccine to other vaccines, it's hard to imagine what the biological plausibility would be for a condition to emerge 2 years after taking a vaccine.
Professor, I think you've really answered this one, but I'm throwing it in. Can the vaccine compromise your fertility?
I have not seen anyone with that, and it'd be hard to know what the biological plausibility would be. So the vaccine goes into your arm. It induces immune response, humoral and cellular immunity, and it would be what would be the mechanism? It's also important to know that these vaccines also do go through preclinical testing in animal studies, and they do what we call a reprotox studies, and look for any red flags. And this has not come out even in the preclinical. So it would be difficult to understand what the biological plausibility would be to making you infertile if you take a COVID vaccine.
Thanks for that, Professor. Now, Pfizer has researched the use of the vaccine for 5 to 11-year-olds and are submitting the findings to the FDA for, I think, emergency use authorization. What's your response to that?
I think it's very important to get our children vaccinated. And we've seen that children in the US, in Europe, in France, in Malaysia, in Singapore, in China, in Chile, have been vaccinated. And they've used Sinovac as well as Pfizer. And so Pfizer is being used in the US in children over 12. And there have been studies in other parts of the world in younger children. And in fact, in South Africa, we are also evaluating the Sinovac vaccine in young children. And so it's very critical to keep schools open, to protect grandparents, and to protect children from COVID. It's important to get them vaccinated. So children should be the beneficiaries of vaccination. So whatever we find to be effective in adults, we should make sure that children are also beneficiaries of these life-saving interventions.
We do have a question. When will 12 to 18-year-olds be able to have the vaccine in South Africa? Is it possible for you to answer that?
Well, I'd hope by early next year. And I think they probably would start with the 16 and 17-year-olds to protect the matric year and then move downwards. It's all about vaccine supply and going to the most vulnerable first and then working your way down as your vaccine supply gets secured. And so I would like to see a case where 12 to 18-year-olds are vaccinated, and then to move down, and obviously for the EPI program, hopefully one day, if you start with the vaccination right at the time of the other vaccinations we give children, it would be a good way of ensuring that we start to take control of SARS-CoV-2 right from the beginning.
Well, Pfizer expects their trials for infants as young as 6 months old to be available later this year. Some of us might be shocked by that, but I think in your world-renowned work in HIV, it can start with toddlers. We shouldn't actually shy away from that. Am I right or wrong?
I mean, vaccinations, we use the primary beneficiaries of vaccines have been children. And there's no reason why COVID vaccines should be withheld from children. And once we see the data from Pfizer and other vaccine pharmaceuticals, we could start having our own determination in South Africa. And I'm sure because we have a supply issue, by the time we start vaccinating younger children, there'll be millions, if not billions, of children who've already received the vaccine at a global level.
I mean, I was surprised that pediatric COVID cases in the US have spiraled by 240% in the last few months.
Yes, and that's also why it's important to look at coverage. So the more people are protected, the more the people who have not been vaccinated will become susceptible. And so you will see in cases in countries where there are high levels of adult vaccination, is that the vulnerable unvaccinated parts of the population will be more susceptible, because they haven't been vaccinated. And so we do expect to see this. We also, as we get to know this epidemic better, we also start to see some of the issues that children face who've got COVID, particularly the young, the 0 to 4 years. We need to follow them up. There's post-inflammatory syndrome, and there are side effects of having COVID that haven't been well described because our focus has been on adults.
Now we get to a rather controversial section of our webinar, and it's the part that scientists hate because you work on data and research. But I'm going to let a Nedbank viewer light the fuse. Can ivermectin be used as a treatment against COVID-19?
I think everything must be data-driven. And from my analysis of the data, the benefits are not clear-cut. And, there's no strong signal that shows protection. So it's nice. It is nice when it's clear-cut, where you can see a risk or a benefit. And with ivermectin, it's difficult from the data that I've seen and the trials that have been done, it's difficult to draw a clear distinction of impact. And so, I would make the suggestion that you should review the data and you should make a data decision, and you should talk to your doctor about whether you should or shouldn't be using ivermectin. And you need to keep abreast with the data and see you can glean any of the data that's coming out of experience with doctors who are using it. So I like to see that the data is definitive, and not that convinced yet that we have a clear-cut data on impact.
Would that apply to most natural remedies?
Yeah, the trials should be well designed, and so you need to see the data, and so with remedies, one should have a well-designed study that can clearly delineate the impact of your intervention on the outcome. And so, I know people do use natural remedies, and as long as one realizes that there may not be data out there to support your use of it.
Professor, let's leave the remedies for a moment, and we've got a question. Is vaccine-induced immunity better than natural immunity from a COVID-19 infection? If you've had COVID, why do you still need to be vaccinated?
Those are good questions. And what we have seen, because of, if the virus wasn't evolving and we still had the original Wuhan strain, and which had not been replaced by Beta or Delta, that would, and we didn't have waning immunity, then one would feel that once you've got COVID-19, you wouldn't have to worry. But we have seen reinfections, so people who got infected in the first wave have waning natural immunity, and have got reinfected in the second wave with Beta, and we have seen people who have been previously infected got reinfected. So reinfection does occur, and it's because of our waning natural immunity. Unfortunately, our immunity wanes. So that's the first problem. If you have had COVID and you get a vaccine, it's like boosting your immune response, and so it'll increase the durability of your immune response and prevent the waning that we see with natural immunity. So it will enhance your immune response. So if you have had COVID and you get a vaccine, that's good for your immunity, because it'll increase the durability of your immune response.
Okay, Professor, let's take a leap into the future. Now, we've got about, 17 million doses administered in this country, 8.5 million fully vaccinated. It's about, 14.5% of the population. Do we have an idea when those who have had the double jab of Pfizer or the single dose of J&J will have to look at a booster shot? In America, I think the FDA has approved Pfizer 3 for use under special circumstances. So where are we now in this country when we have been jabbed and another dose may be due?
Yes, I think first and foremost in South Africa, we've got to get a vaccine into the arms of people who need it before we start thinking about boosters. That's important for vaccine equity.
Okay.
But for healthcare workers, we're already looking at boosting healthcare workers. So people who were on the Sisonke study, we're in discussions about boosting them in end of October, early November, before the next wave. And so there's a great desire by healthcare workers to be boosted, and which I think is great for vaccine hesitancy, because if doctors and nurses are lining up to be vaccinated, that should create some hope. They don't just want one vaccine, they want another one. And so I think it's important that we look at the boosting and try and understand the timing. It's obviously, it would be nice to be in a situation where we only had to boost once a year. And I think that would be the best scenario for us. And we'll watch the countries that are doing the boosting of the Pfizer. I think we will watch and look at the data to evaluate what we need to do in South Africa. But at this moment in time, we don't have the luxury of considering a third dose of Pfizer and reevaluating a second dose of the J&J in healthcare workers to drive policy and to understand the value of an additional boost with the J&J jab.
Professor, I would guess it's obviously it's obvious that you are concerned about the speed of the rollout.
Well, I think we've been the supply issue has always been a problem in our country, and it took us many months to secure the supply. And this was because of, calamities out of our hands. We know that the J&J vaccine that we procured had to be destroyed because of contamination in the Baltimore plant, and the great demand for Pfizer at a global level has impacted on a low middle income country's ability to navigate when they're big countries with big money and large amounts that they need. And so given the fact that I think we're now in a situation where our vaccine supply is secure, we can start to look for trying to improve the coverage. And if you look at South Africa, we probably are now at the moment the most vaccinated country in Africa, in comparison to the other parts of Africa. So we've done incredibly well in that short period of time, which speaks to how well the system was working for vaccines, and gives you great hope that we can use the vaccine rollout as a way to strengthen our health system. If we can do this for vaccinations, then we should be able to improve the health system in our country for other conditions as well. It gives me hope that we can fix our health system.
Another question from the floor, as we used to say. Does the flu vaccine provide protection against COVID-19? I don't know if you've got any research or data on that.
Well, there's no data. I mean, we have to look at why does a COVID vaccine protect? It protects because the immunogens that are in the vaccine, the spike protein, induce an immune response that when people are exposed to the virus, you induce a neutralizing antibody response, binding antibody response, and CD4 and CD8 T cell responses. And so it's immunogen specific. So it's unlikely that a flu vaccine, because it doesn't contain the spike protein, would protect you against COVID-19.
Professor, I'm going to ask you to take us into your world. What is the latest research when it comes to variants, and which countries around the world are under the most threat right now?
So we worry about poorly vaccinated countries and countries that don't have enough coverage, because that's where variants are likely to emerge. And so obviously Africa as a continent is a great concern because there's not a lot of surveillance outside South Africa, and there's not a lot of testing. And so it's very hard to get a handle on the disease in Africa. So what worries me around viral evolution is low vaccination pace and poor vaccination coverage, and then also immunosuppressed people who may be shedding the virus, who may lead to viral evolution. And I think that is why there's a huge need to increase vaccination rates in South Africa to help control viral escape and evolution.
Thank you. And what is happening here in Africa and around the world when it comes to researching new vaccines or other methods of controlling the pandemic that just could give us a little bit more hope for the future?
Yeah, I mean, I think one of the exciting things that we may see is on the therapeutic horizon. And so although we have vaccines against COVID, we don't have good therapies. And that's why we resort to a whole lot of other things. But we do have monoclonal antibodies that are being developed. And hopefully there'll be some emphasis on antivirals for COVID. So the therapeutic front has lagged behind the vaccine front. And for vaccines, there's a lot of work being done at a global level. So there's work in activated vaccines. There's research with DNA-based vaccines. There's research with nanoparticles and vaccines. And there's also obviously research looking at the viral evolution and looking at inserting the new variants as part of your vaccine. So you might see bivalent vaccines that have both the Wuhan strain of the spike protein in plus a delta or a beta variant. And so we will see that vaccines may become what you call multivalent, have various from various strains and have various inserts from various strains in your platform. We might see adeno-5-based vectors coming in. Oral, there's work on oral vaccines and work on subunit vaccines. So a lot of work is being done to make the portfolio of vaccines wider, and the more vaccines that are in, that have been shown to be effective, the cheaper the vaccines will be, and you can drive down the price when there's choice.
Now, this is quite a complicated question. Is there a risk of creating a herd of virus carriers when we get to, say, 70 to 80% vaccinated, hopefully? Vaccinated people who get infected and are virus productive, but with almost no symptoms and therefore not testing or isolating. Does it make sense?
Yeah. I mean, I think what we need to do is we need to observe the data coming from countries that are highly vaccinated and have good surveillance to try and answer those questions around, how much virus do you shed? So obviously we do expect breakthrough infections. If you get vaccinated, it'll protect you, it'll reduce your risk of dying or being hospitalized or having severe disease, but may not protect you from getting an infection. So you may have breakthrough infections. And it's important to evaluate the shedding, the nasal shedding of people who get vaccinated, and to see whether this impacts on onward transmission. We have seen there are some transmission studies going on at a global level to follow vaccinated people and see their impact on community transmission. And we have seen indirect evidence from households and communities where vaccine coverage is high, is that there's a reduction in the number of cases of COVID. And obviously, once we have highly vaccinated communities, it's important then to do surveillance on shedding, like we do at the MRC. We have what we call a wastewater surveillance, and so we look at the sewage of communities, and we look for SARS-CoV-2 there, and we look for variants, and that'll be an indirect way and non-invasive way to follow what's happening with variants without having to swab people's noses. You just have to go to the sewage. And at a global level, there's a lot of people working in sewage to try and track and answer these questions that the viewer has posed, and they're very important.
Now, we're not even through this outbreak, and we're worrying about the next wave. What can we do to prevent it or minimize it, or is it pretty obvious?
We have our non-pharmaceutical interventions that we need to adhere to. We have to hand cleaning, mask wearing, ventilation, and making sure that we don't conglomerate in crowded spaces. And obviously, vaccination is an important tool in that. It's an additional tool that will help us get our economy back and get our lives back. And so, I can't see us throwing away the mask, or not washing our hands, or not advocating good ventilation for many years to come, and while we battle vaccine coverage and the local dynamics of SARS-CoV-2 transmission.
One thing that has been a bit confusing is this question of the FDA. This distinguishing between approval and authorization. What is the difference?
So the issue with the FDA and I guess with all the regulatory agencies is initially when Pfizer and Moderna applied for registration, it was granted as a EUA, emergency use listing, as data is accumulating in that period, and then you're using that data to evaluate the safety and the effectiveness. So Pfizer then goes from the EUA to a registration, and as the regulatory authorities are satisfied with the data that's coming through from the rollout, they can then upgrade you to full approval. And that's the process that the regulatory authorities work with. They ask for specific data. They are interested in conditions of concern. they're interested in the safety and effectiveness, and want to make sure that they satisfy all the conditions before they upgrade you to full licensure.
And Professor, I would take it that you and your colleagues don't just rely on FDA findings, that you do your own tests and research.
But it's important for us in South Africa to do our own, because we have our own local unique conditions like HIV and TB, and we have a much younger population than you see in the US. And so it's important for us to have local data on safety and effectiveness. And in fact, the data that we have in South Africa, particularly around the J&J vaccine, was critical for actually its use in other parts of the world. And we would, some of the health authorities who were starting to use J&J would consult with us, because at that stage we had more experience than anyone else in the world as we rolled out the Sisonke. So at one stage, the only experience, large-scale experience we had with J&J was in South Africa.
Professor, before I hand you back to Zanele, what can we say to those who are vaccine resistant or plain anti-vax to get them on board, to get more people taking the jab?
Well, I think you need to understand what are the concerns. And, I guess the first concern is trust, is that there's a lot of mistrust in the world, and try and understand, what are the trust issues, what are the concerns, and try and address those. But the most important thing, I guess, is personal experience. Sometimes, we had seeing someone die who couldn't get vaccinated. Before we had rolled out our vaccines, I had scientists who worked with me that died. And that for me was devastating, to know that if that vaccine had been there, she wouldn't have died. And my other colleagues that have died because we couldn't get the vaccine to them in time. And also seeing people who are anti-vaxxers. So we had an anti-vaxxer who worked in one of our buildings, an openly anti-vaxxer, and unfortunately her dad got COVID and died, and she got COVID and died. And and I wish maybe I'd spent more time trying to understand their reasons for not wanting to vaccinate. People are scared about safety, and maybe we don't spend enough time explaining about the vaccine and explaining about the rare events. And I think that's also important. So maybe a lot of the issues that we face is just because there's been poor communication. Maybe doctors and scientists are not good communicators, and so we haven't communicated in ways that give the public confidence. And we need to get better at that. And maybe we need to try and understand what the concerns are and try and address them, so that we can infuse confidence in people. Millions of people in South Africa have got the vaccine, and billions of people at a global level have got the vaccine. If you look at it's always important to watch the CDC postings on the side effects to allay your fears, and to look at death rates. And at a global level, one has to investigate vaccine-related deaths and see whether what were the predisposing conditions. Was it an anaphylaxis? Was it a vaccine-induced thrombotic thrombocytopenia? But from what I can see, vaccine-related deaths is kind of 0.0021% in the US. So it's a minuscule amount, and so the risk-benefit at this moment in time is in favor of the vaccine. And there's been no global safety alert that has stopped the global rollout. And so I think we have to be confident, seeing the fact that billions of people have got the vaccine all over the world, and there've been no, there hasn't been any red flags from those billions of vaccine users, and so we should learn from the global experience.
Professor, you are, as a scientist, obviously, you are also an activist, I think. But do you at times get emotional about the situation, get into heated discussions with your friends and colleagues?
And I think for me, I guess when people die who are anti-vaxxers, I'm sad because that death could have been averted. And if people get side effects from vaccines, it's important to talk them through it. We mustn't shy away from difficult conversations. And if people are scared about the side effects, let's talk about them and quantify them and manage that. And I just hope for the people that are anti-vaxxers that they're going to be safe.
Just to wrap up my side of the presentation, how do I manage all the information that is out there? What to believe and what not, who to believe? Can you provide creditable websites or an expert page, which I guess is on your website?
Yeah, we look at the Medical Research Council, but the CDC is great. And, you can look at the other WHO and other countries, Public Health England. So if you don't trust the South African data, go to the Americans. If you don't trust the Americans, go to the British or the European. So there's a lot of data, from research agencies and regulatory authorities and departments of health that have got oodles of information that you can use. So I would recommend that you look far and wide to get the information you need and don't just take it from one source.
Mm-hmm. Professor Glenda Gray, it's been an absolute pleasure chatting to you. Please stand by. Zanele has got more questions for you, but bye for now.
Thanks. Bye-bye.
Thank you. Thank you very much, Derek. Thanks, Professor Gray. The conversation has really sparked quite a few questions. I've got questions from the audience, which I will just put through to you, Professor Gray. I'll just start with answering quite a few from the audience who want to know whether there will be a recording of this webinar. Yes, there is a recording. You will receive an email with the link to the recording. Then you can just forward to your friends or watch it at your own time. Professor Gray, there's quite a few questions around the Novavax vaccine. The questions are around whether it will be approved and available in South Africa. If not, which other closest vaccine to Novavax would be available?
So the Novavax data is at a global level is becoming available, and I guess a vaccine like Novavax or any other vaccine can be registered in South Africa if the companies apply or submit their dossiers. So it all depends on whether Novavax has submitted their dossier to SAHPRA for them to evaluate and see. So I think that's the most important thing. SAHPRA doesn't go out and ask for vaccine manufacturers to submit their dossiers. They wait for the dossiers to be submitted, and then they have a conversation with the manufacturers, and often there's a rolling submission as data gets accumulated, or there's a conditional approval. So at the moment we have J&J and we have Pfizer, and we have an evaluation of Sinovac at the moment. Sinovac has to perform certain studies in South Africa for its while it's been rolled out under the regulatory authorities. So they're doing the pediatric study at the moment, and there are other studies that are required while their submission is while vaccines will be used here. So depending on the regulatory authority, they will either allow you to use your vaccine here based on global data, and then ask you to do certain data ask you to perform certain studies in the country so that you can fulfill the requirements of the approval. So we've got that, and there's also a submission by Sputnik that is being considered. And I guess the same thing will happen as with Pfizer and with J&J, is that certain conditions need to be fulfilled before the SAHPRA can register or allow the product to be used in the local situation.
Thanks, Professor. There's also quite a few questions around people who recently had COVID and some had long COVID. And they want to know, is there a waiting period before they take the vaccine?
So I think we give the advice that you should be 28 days free of symptoms before you get your vaccine. And if you had if you were in ICU or in hospital, we've suggested you wait 28 days before you get your vaccine. And this is what we did for healthcare workers, because obviously they were highly exposed individuals and we wanted to protect them. So, so there are other agencies that recommend 90 days after your COVID infection. So, so I would suggest that the person who treated you for your COVID, you have a discussion with them. They know you very well and they would give you the best advice, but anything from 28 days onwards for me would be acceptable. In terms of long COVID, I've heard that vaccination can assist long COVID, but that data is accumulating and hopefully there will be an impact on long COVID post-vaccination.
Thanks for that, Professor. And there's another question around people who have been seriously had adverse reactions to the vaccines, and they are now despondent. What care is available to those people? What kind of support is given to them?
Well, I think I think it depends on if is this a Sasonki program or is it the national rollout. There is the NHLS has a safety desk and a call line that they should speak to. If it's a Sasonki participant, we do have a safety desk that interfaces with the people who receive the vaccine. I would say, don't be despondent. Together with your doctor and experts in vaccine research, work with them. So a lot of people contact me who took the Pfizer or took the 826 in the government rollout who've had side effects, and we've worked with them and their doctors to support them in it. The side effects that we expect to see, we know what they are. There are rare side effects, and that we know they occur between 4 to 8 per million. And these rare side effects are, myocarditis or pericarditis with Pfizer. Guillain-Barré syndrome has been described with the adeno 26, the J&J jab, together with the Pfizer, lower rates with Pfizer than the J&J, and then the vaccine-induced thrombotic thrombocytopenia. So those are the rare side effects, and if detected and managed properly, people will do well. It's when the rare side effects are missed is when people don't do well and people become despondent. And so, I think that I'm sorry to hear that people are despondent, and hopefully that they can work together with their service providers, their healthcare providers to try and mitigate the side effects that they're feeling around after receiving the jabs.
I'll take just two last questions. There's quite a lot of questions here, but I'll just do the last two in the interest of time, Prof. The people who really want to know what are the pros and cons of the J&J and the Pfizer. I suppose the question is really, is there one that's better over the other?
All the vaccines work, whether they Sinovac, J&J, and Pfizer. And I think that it's hard, it's hard to AstraZeneca, they all work. and they're all well used all over the world. And so I would, for me, I would take what I could get at this stage. I volunteered in the AstraZeneca clinical trial before before the data was out, because I was worried about COVID. And so I think it's important that we realize that all vaccines work, and that as long as we can get one, that's the most important thing. And I wouldn't differentiate between the two. The advantages of the J&J jab, it's a single jab. It's got good cold chain distribution for rural use, and you don't have to go back again immediately. The disadvantage of Pfizer is that it has some cold chain challenges, and you have to go back for a second jab. But they're both very good vaccines, and it's hard to choose.
Okay, thanks, Prof, for that. Last question, and I think you did touch on this question, but I'll ask it because there's quite a lot of people asking the same question around the booster shots. There's talks that the booster shots last for 6 months, and some people are saying we would need to take booster shots every single year. What is your take on it, Prof?
So we've seen that there's long-term durability. So we've been following people who got the single shot J&J and see that even out to 8 months, there's durability of it. And so we will be able to answer the question for J&J this year, because we will be able to offer the Sisonke participants a boost in October, November, which will give us lots of data on durability. And plus, there are other studies at a global level that are looking at durability. So we'll be able to know the timing of boosting going forward. And the same with Pfizer and Moderna. With the advent of the third dose, there is immunogenicity studies that will go with those, and which will give us information about what does the third dose do, and how long does immune response last after you've had the third dose.
Thank you. Thank you so much, Professor Gray, and thank you, Derek,
thank you,
for hosting such an amazing conversation with Professor Gray. Before we log off, once again, just a reminder that you will get a link, an email with a link to the recording of the webinar. And on the 18th of October, we would also have a smaller session of webinars where we will be unpacking the impact of COVID-19 on personal finances. If you'd like to be invited to this webinar, please just put your name and surname on the left-hand side, and you put finances as a topic keyword on the chat. We would make sure that we do invite you. And also note that your details that you're putting in there will only be visible to the webinar administrators. Please remember, you can always get more thought leadership information on the recordings, and you will get it on our websites. Lastly, your views matter to us. Please help us to improve our future webinars by giving us your feedback in the brief survey that you will receive via an email in the next few days. Thank you everyone for joining us. Go well and stay safe.